And today we have a very important journal scan. The webinar is on journal scan, critical appraisal of the journal articles. And I'm so happy that this is going to be moderated by none other than Dr. Sunanda Gupta. She is so well known to our anesthesia fraternity, the obstetric fraternity, and she's a close friend of many of us, and she's a very senior member of the ICA, Indian College of Anesthesiologists. Sunanda, thank you so much for accepting this program. And should we start, because there are going to be several journal presentations, which I'm sure are going to be very interesting, and we should start right away. Sunanda?
Thank you very much, Dr. Su, and welcome to all the participants in this webinar. So, okay, I hope the screen is visible.
Yes, ma'am.
Okay. So, thank you very much, and a very good
Sunanda, can I
Yes.
just introduce you officially? Madam is an Emeritus Professor at the Geetanjali Medical College, Udaipur, and she has many awards and many distinctions and many feathers to her cap. Difficult to enumerate all of them. And thank you, Sunanda. Please go ahead.
Thank you, Jayashri. And so today it's a pleasure to be here at the 167th webinar for this critical appraisal of 3 recent journal articles we have sourced from various obstetric journals. And I welcome our 3 panelists here. So, yes, the first one is Dr. Anjeleena, and she is an anesthesiologist, a consultant at the Ganga Hospital, and she is also an executive member of the Association of Obstetric Anesthesiologists. The second panelist is Dr. Kajal Jain. She is president of our Association of Obstetric Anesthesia and also a professor at PGI Chandigarh. And the third panelist is Dr. Shilpa Kasodekar. She is chief of anesthesia and a joint secretary of AOA, and she works at PDA Hinduja Hospital. So, without any prelims, we are going on to our first article without wasting time, and it is cardiovascular effects of oxytocin and carbetocin at cesarean section. And this is an article which has been published by Rabau and his group, who come from Sweden, and it has been published in the Journal of Maternal, Fetal and Neonatal Medicine recently in 2023. And they have compared 2 posterior pituitary hormones and their synthetic analog, which are used as the first line uterotonics. Just to recapitulate, these are the posterior pituitary hormones and analogs, oxytocin and carbetocin. And the second line is the ergotalcoloids, the ergometrin and methylergometrin. And another second line is prostaglandin S analogs, PGE2, misoprostol, and carboprost. Though we have so many of uterotonics, at present, oxytocin is considered the gold standard. And recently, on the other hand, a synthetic analog of oxytocin having a longer half-life due to its structural modification has found its place in the WHO essential drug list. And it has been in 2018. And a recent trial in that is called the Champion trial, which was conducted by WHO in 23 centers of 10 countries. And it involved about 30,000 women, and India was also a participant here. They looked at the heat-stable carbetocin versus oxytocin to prevent hemorrhage after vaginal birth. And They also looked at carbetocin as an alternative uterotonic, considering its heat stable properties for 3 years at 30 degrees centigrade and 75% relative humidity against 2 to 6 degrees centigrade temperature control, which is required for oxytocin. Now, it has been heralded as a drug which can save thousands of women's lives in low and middle income countries, according to WHO. So I thought that we all thought in the panel that the cardiovascular effects of this drug would assume a great importance and would be of general interest to everyone around. The second important article which we chose was the a study from Repucci et al., which was who comes from the University of Colorado, and it was published in Anesthesia and Analgesia in 2023. It is detection of postpartum hemorrhage using compensatory reserve index in patients who undergo cesarean section. And as you all know, we lose nearly 70,000 women to postpartum hemorrhage, a leading cause of maternal mortality. And one of the most important reasons we are not able to save these mothers is because early on we cannot quantify it and neither detect it. There's a humorous take on it. Surgeons saying that it is just 50 ml of blood which is lost in the operating room. And so delay in management is because we are not forewarned. The window period to save these women as uterus pours out blood at 600 to 800 ml per minute. And if you calculate, we have just 6 to 7 minutes before she is totally exsanguinated and irreversible shock sets in. So to forewarn us, we have at present the modified obstetric early warning scores, the obstetric shock index, but then physiological collapse, as you can see, occurs so abruptly in these patients that recognition or diagnosis based on monitoring standard vital parameters or biochemical parameters may not be apparent unless compensatory mechanisms start failing. And by then, our uterotonics, tranexamic acid, and many of the other drugs lose their efficacy. So this is a new index which has been brought in, the compensatory reserve index, and let us see whether it can prove a forewarner in the early diagnosis of postpartum hemorrhage. The third article which we selected and was published in Anaesthesiology in 2022 by Lionel Beauvais and his team, who come from France. And this looks at pregnancy and labor epidural effects on gastric emptying, a prospective comparative study. And why exactly did we select this topic? First of all, as you know, there is a delay in gastric emptying in pregnancy, and peripartum aspiration is of a great concern for us. Secondly, there's a lot of discrepancy on whether solid food should be allowed during labor. And if we give solids, if the patient is receiving labor epidural analgesia, will it further decrease the gastric motility and make them more susceptible to the dreaded Mendelssohn syndrome? That is one of the queries we have. And so can we use gastric ultrasound to estimate the antral gastric circumference? The two major guidelines around the world, the ASA as well as SOAP and the European guidelines, have not reached a consensus on whether we should allow women during labor to have fluids as well as a light meal. So the ASA and SOAP both say that the laboring woman, parturient, can have moderate fluids, but no solids or light meal should be given to the mother. Well, the European guidelines contradict it and says, yes, we can give fluids as well as a light meal. So in this context, it is an important article to guide us whether we need to keep our mothers fasted or we need to keep them fed. So with this, I invite Dr. Anjeleena to start the first article and talk about whether we really need to switch over to carbetocin in the long run.
That I would like to thank the organizer, Dr. Muralidhar Kanchi, Dr. Radhik, a part of this journal scan. Can I
switch on your video, Anjeleena?
Anjeleena, we cannot see you. Your video is off.
Hello, ma'am.
Yes.
Ma'am, actually, Anjeleena ma'am is not in the meeting room. Maybe she's facing some network issue. I hope she'll be joining again.
Okay, so can we go on to the second one? Dr. Kajal, can you do your presentation then?
Yes, ma'am.
Anjeleena comes in.
Yes, ma'am.
Yeah.
Is my screen visible?
Yes.
Okay, ma'am. So I'll just put it on slide. Yeah. Is it
Yes.
visible, ma'am?
Yes, yes.
Okay.
It's visible.
But I can't see my, yes, I can see myself also.
Anjeleena, we'll go on to your slides after Kajal finishes.
So, ma'am, a very good evening to all of you, the ones who are in the audience, as well as those who are in the faculty Zoom gallery. And it's my extreme privilege to be once again on board with the webinar focusing on latest articles done under Indian College of Anesthesiologists. It's a very indeed an honor to be participating in this event today. So as Madam had rightly said, that postpartum hemorrhage is a leading cause of death, and we need to detect women who are losing blood very fast so as to save the morbidity and mortality. And this article at this point of time comes as a novel marker of managing these patients. This article has come only recently in Anesthesia and Analgesia, which is a very well-reputed journal, and it has been written by a group of people led by Marina Repucci et al. This article was also presented at the SOAP meeting, and it had won the Best Poster Award. So to introduce the topic, we always take postpartum hemorrhage, which is more than 1 liter blood loss within 24 hours. And there are many risk stratifications to tell us that which woman would be at risk of losing. We also use vital signs, laboratory values to quantify blood loss. But having said that, there are many women who still lose blood, and these signs and laboratory values are of limited use in many scenarios. So that is the reason we are not able to manage these women very effectively. And then there is clinical dilemmas as to give fluids or to start with inotropic support, and or you are to be guided by your base deficits or the lactates. So all this is happening when the compensatory mechanisms, they began to fail. So this is also super added by the delayed recognition of hemorrhage, which we all know happens most of the times because the quantification of blood loss is very poorly done in most of the centers. So this is why this topic needs another look, and how do we manage those women who are bleeding actively. So just to introduce the topic, the main keyword of the topic, that is the compensatory reserve index. Actually, compensatory reserve index is a new physiological monitoring parameter which trends with intravascular volume and can be used by clinicians in conjunction with other hemodynamic measures to assess volume status. So you can see I have put one finger probe. It is just about a finger probe which is attached to a monitor. And then there's a waveform which can be mapped just like a simple pulse oximeter. And there are waveforms trending which shows us like variations And these variations are numerically, given. We'll be talking about that. So what are the numeric values? So those numeric values, if they fall out of range, you can say that the compensatory reserve index is high or low. So it uses a standard photoplethysmograph waveform, and it can be applied at any point. That's a good thing about it. It can be applied at any point during volume changes and does not require any reference values. So this is how it looks like. This is available from this company, noninvasive, and it has got a header in which you can see there's a green button which signifies that the monitor is on, and you can see the parameters like heart rate and compensatory reserve index and saturation coming here. And basically it is just trending the changes which are depicted in the graphical format, and it is valued anywhere between 0 to 1. So these are the bottom two. So this is how the waveform comes. If the patient is normal and healthy, this compensatory reserve index is falling up to the range of 0.8 to 1. If the patient is suffering moderate intravascular hypovolemia, it falls down and it comes in the range of 0.4 to 0.6. But if your patient is bleeding massively and the volume losses are happening at a very fast rate, then the values go very low, and you can see the numeric values touch 0. So this is an algorithmic approach which can correlate with your clinical states, and this is what the authors have used in their study. So as I said, 1 represents supine normovolemia, 0 is predicted point of hemodynamic compensation, which can be also taken that the patient is having systolic blood pressure of less than 80 with or without bradycardia. So it is calculated with this estimated volume, and this is how CRI is plotted. On the X and the Y axis, you see on the X axis, you have the CRI values, and on the Y axis, you are having what is a blood loss. So in the first subject, you can see like CRI values are very high, like 1. And as the subject loses blood, how the values drop down as a steep curve. If you resuscitate and you keep your values above 0.7, even with greater losses, like then the patient's he's tolerant to the blood loss. So compensatory reserve is the unique capacity. So we all know that there is a certain limit to which our body is able to compensate. That's the compensatory reserve in a layman's language. If you say it scientifically, it's a unique capacity of the cardiovascular mechanisms to compensate for the intravascular loss of an individual, which an individual can tolerate before experiencing the symptoms of cardiovascular instability and decompensation. So this CRI catches these patients before this happens. So that's what they are saying. And this is the hypothesis the team generated. They said that CRI will detect compensatory changes in women who experience postpartum hemorrhage during a cesarean delivery. So for this, they determined the differential between those patients who experience PPH compared to those who do not. And as a secondary outcome, they determined whether CRI had any advantage to detecting such differences when compared to the mean arterial pressures. So this was a prospective observational study conducted in the University of Colorado Hospital, USA, and it was conducted between the months of February 2020 to May 2021. They took in their inclusion criteria all pregnant women who were more than 18 years of age and were undergoing planned or unplanned cesarean section during the study period. They also took into consideration the risk factors which can lead to bleeding, like obesity, grandmalty, advanced age, anemia, gestations, macrosomia, preeclampsia, and abnormal placentation. So when the patient was wheeled into the OT, this pulse oximeter was attached and the values were recorded. They were recorded every 5 seconds by the device, and along with that, authors took demographic data, obstetric data, delivery data from the electronic medical record. So just to, the pure blinding was not possible, but what they did is the tablet which showed the parameters was kept under the operating room table so that the surgical and the anesthesia team could not watch what the values during the study period. That's how the blinding was done. And then all patients were subjected either to general anesthesia or spinal anesthesia. They recorded the intraoperative fluid volume given, the blood losses which happened, and whether the blood and blood products were given. They also recorded whether additional uterotonics and what were the uterotonics given, whether tranexamic acid was given during this peripartum period. And then patients were stratified by blood loss, like PPH and non-PPH. That is more than a liter loss or less than a liter loss. So data was analyzed using a software version 4.1.2, and sample size was based on the ability of a 0.05 decrement in CRI to detect a decrease in volume of 45 ml with an area of curve under 0.9. So these are like basically like they saw about CRI and with respect to postpartum hemorrhage, and then they drew some curves. So in their results, they had actually enrolled 67 patients, out of which 51 completed the data. 38 women fell into the non-PPH group, means they did not have more than a liter loss, and 13 were in the PPH group. 49 patients with scheduled SED, cesarean delivery. 2 patients in each group were laboring and proceeded to cesarean delivery. There was 1 cesarean hysterectomy for placenta accreta. Some patients were excluded because of refusal, vaginal delivery, or incarcerated fetus. So this is what they found. In their overall sample, if you look, these are called the, the curves, the smoothened out curves after filtering the data, which is like contaminated due to noise and all, because it's being recorded every 5 seconds. So what they've seen is that the compensatory reserve index in patients who had no PPH was showing a value between 0.7 to 1. Whereas those who had PPH, the compensatory reserve index showed a lower value between 0.6 to 0.7. And this happened when there were no changes in mean arterial pressure, or if there were mean arterial pressures, then they were not statistically significant. So that means that these graphs were able to tell that those women who had lost 1 liter of blood were showing your compensatory reserve index between 0.8 to 1, signifying that this is picking up faster than the mean arterial pressures. And if they further segregated the data and took out non-preeclamptics from the sample, they saw that in non-preeclamptics, the average CRI values were lower in pregnant patients who hemorrhaged. So with a confidence interval falling between 0.18 to 0.19 and a p-value which was significant, 0.001. Whereas there was no statistically significant difference in the MAP values between those who hemorrhaged and those who did not. Similarly, in preeclamptic patients, they found that in no PPH group and PPH group, there wasn't much difference. So this segment needs to be studied further, because we all know in preeclampsia, there is endothelial damage. It's a multi-system disease. The vascular tones are high. So whether we should interpret preeclamptics also with CRI or no needs more studies, because the sample contained only 4 women in this study. So if you go on to discussion, so this is the first prospective study investigating the utility of compensatory reserve index in identification and peripartum monitoring of women at risk of PPH. And the results show that CRI values are reduced in patients who experience PPH during cesarean section compared to those who do not. And compared to standard monitoring, CRI values were lower with or without preeclampsia, and MAP values were not significantly lower in either group. This is very important, that MAP values did not alter. So this study shows that decrease in central volume status associated with hemorrhage in obstetric patient are detected earlier by CRI, and this technology may serve as a useful monitor during delivery. So previously, if you review the literature, it has been extensively studied in trauma patients. There have been approximately 30 studies where CRI was able to identify hemorrhaging patients in trauma victims. So it had a higher sensitivity than standard vitals like heart rate, BP, shock index, or lab values like base deficits and lactates for identifying patients who were bleeding. So lower mean CRI value in those who were actively bleeding compared to those has reported differences. This is one study, which is the only study which has been done in obstetric patient. This came in American Journal of Obstetrics and Gynecology, there were 48 patients who were recruited for who were undergoing scheduled cesarean section, and CRI values decreased from 0.78 at the time of skin incision. These are all under spinal anesthesia. To 0.68 at the time of placental delivery. However, this study did not report, any quantitative blood loss. This was just one primary study in which they were trying to see how are the vital signs vis-a-vis compensatory reserve index. So this study, to conclude, has certain limitations. It's only a single center study with a small sample size. And since this is a tertiary care center where the study was conducted, the authors felt that they had high risk parturients who are already prone to a risk of hemorrhaging. And there are certain confounding factors, which I've already spoken about, like change in vascular tone in severe preeclampsia or anesthesia-induced sympathectomy, which were not taken into account. And this segment needs to be studied further. Also, there are changes in cardiac output even before changes in MAP occurs. So authors are also suggesting that further studies should look at the correlation of CRI with cardiac output changes. So study only reported linear differences between CRI for the 10 to 60 minutes following delivery, and they did not study it further. So these things remain to be understood in the future course. And till that time, I think we should wait. And another thing which I could not find was what was the cost of this equipment and whether authors had any conflict of interest with this. Since it has been already used and FDA approved, I think there should be no conflict of interest. But the cost of this equipment was, I could not find. As such, we all know that Massimo pulse ox, which does SPV and PPV, is costing around 10 to 15 lakhs. So I think it will fall around that much. Thank you very much.
Thank you, Kajal. And I think we'll go over to Anjeleena. Anjeleena, are you ready?
Yes, ma'am.
Okay.
Yes.
So
I'll
can
just
start.
share my screen.
Yes.
Can you see my screen?
Yes. Yes.
Good evening, everyone. At the outset, I would like to thank the organizers of Indian College of Anesthesiologists, Dr. Jayashree Sood ma'am, Dr. Kanchi, Dr. Radhakrishnan, and especially Dr. Sunanda ma'am for making me a part of this journal scan. I would be presenting this very important topic, which was published by Rabos on the cardiovascular effects of oxytocin and carbetocin at cesarean section, a prospective double-blind randomized study using non-invasive pulse wave analysis. First, the question comes that why did I choose this topic? Well, India is a developing country, and we have a very high maternal mortality rate of about 97,000 per 100,000 live birth. And the main reason is hemorrhage, where postpartum hemorrhage is the leading cause for it. More so, WHO recommends using prophylactic uterotonics, and we all know we've been using oxytocin as the ideal uterotonic. But the problem is that oxytocin requires a cold chain system for the maintenance of the active drug ingredient, which is often very difficult in our system in India, where we have rural setups, where there is difficulty in maintaining the cold storage. Therefore, recently, carbetocin, which is an octapeptide analog of oxytocin, has received approval from the WHO as the uterotonic. But we do not have specific guidelines for its use in different scenarios. So we chose this topic. And we know also that oxytocin has a very short half-life of 1 to 6 minutes, and therefore it requires repeated administration. It is generally given as a bolus dose followed by an infusion. And this is associated with receptor desensitization, and over a period of time, it can result in deteriorating uterotonic effect. More so, there are also cardiovascular side effects associated with it, like chest discomfort, tachycardia, hypotension, as well as ST depression. On the other hand, this recently approved carbetocin is heat stable in nature, and it has a longer half-life. So within once carbetocin is given, it causes sustained uterine contraction lasting about 60 minutes. And we have to see that because of its longer half-life, are these cardiovascular side effects also going to stay a bit longer? So the authors tried to compare the effects of carbetocin on oxytocin on the arterial elasticity and the hemodynamic parameters. They received the approval from the Research Ethics Committee, and it was also pre-registered by the Swedish Medical Products Agency. They assessed 85 parturients for eligibility, depending on the inclusion and the exclusion criteria. They included any women between the age of 18 to 40 years with ASF physical status 1 and 2, with more than 35 weeks of gestation, with a singleton pregnancy for elective cesarean section under spinal anesthesia. But however, if the parturient had a significant cardiovascular or a lung disease, hypertension, preeclampsia, non-gestational diabetes mellitus, or taking any medication which affected the cardiovascular system or required a general anesthesia, then they were excluded. So therefore, there were 3 patients who were excluded because of not meeting the inclusion criteria, and 21 declined to participate. So finally, they randomized 61 parturients, 30 in the oxytocin group and 31 in the carbetocin group. The primary objective was to look at the hemodynamic parameters, the heart rate, mean arterial pressure, ST index, and the oxygen saturation, while the cardiac performance and the arterial vascular tone was assessed by the digital pulse analysis variables, which are derived from the digital photoplethysmogram, that is the aging index, left ventricular ejection time, which is compensated to a heart rate of 60 beats per minute, dicrotic index, the ejection elasticity index, the pulse height, and the ratio of the second derivatives of the reflected wave, which is then obtained from the acceleration photoplethysmogram. These you can see on the diagrams below. The secondary objective was to look at the uterine tone, the need for any additional uterotoning, the volume of the vasopress and the fluids, the total amount of blood loss, and if there was any parturient complaining of chest pain. The sample size calculation was based on the mean arterial pressure from the previous study of the authors on intravenous oxytocin, where they found there was a drop in blood pressure from 79.3 millimeters of mercury to 72 millimeters of mercury, with a standard deviation of 10 millimeters of mercury. Considering this data, and with a type 1 risk of 5% and type 2 risk of 20%, they calculated that the sample size should be 29 per group. But since there were dropouts in their previous study of 10 to 15%, because they were missing values or they were erroneous values secondary to movement of the fingers or by cold fingers, so they considered 40 parturients to be included in each group. All the patients got an IV access and ringer acetate was started. Standard monitoring was performed, which included a blood pressure cuff, a ECG lead 2 to look at the ST index, and also a pulse oximeter, which was placed on the second or the third finger. And this was then connected to the DPA meridian apparatus, which you can see on the right side, and it was connected to the laptop. Subarachnoid block was given to the patients, and phenylephrine infusion was started to stabilize the blood pressure. After this, the block height was assessed and the surgery was started. After the delivery of the baby, the baseline measurements were taken at T0. Then, depending on the group, the bolus study drug was given. In the oxytocin group, 5 units of international units of oxytocin, which corresponded to 8.3 microgram oxytocin, or a carbetocin 100 microgram was given over a period of 1 minute. And the further measurements were then taken at 1, 5, 20, and 60 minutes after the completion of the bolus dose, which was named as T1, T5, T20, and T60. T60 measurements were taken in the recovery room. During this period, the DPA analysis was started, which took about 70 seconds to perform. And during this time, the surgery was halted. The uterine tone was assessed at T20, wherein 0 was complete uterine inertia and 10 was the maximum uterine contraction. And even the chest pain was assessed at T1 and T60. If any parturition required any additional drug, or if there was a blood loss of more than 1,000 ml, then these parturins, their subsequent readings were excluded from the analysis. The statistical analysis was done by a sigma plot 15 computer software, and the longitudinal drug effects were seen based on the one-way repeated measurements ANOVA test, while the comparison between the two groups was done by two-way repeated measurements ANOVA. There was no statistically significant difference between the patient characteristics or the baseline measurements. Also, the comparison between the two groups showed no statistically significant difference, with the p-value was more than 0.1. As we can see in this graph, with regards to the heart rate, in the oxytocin group, there was drop in the heart rate at T1 by about 9 beats per minute, and then it recovered back at T5 to that of carbetocin. Throughout the study duration, the heart rate remained low, and at T60, it was 10 to 13 beats per minute lower than the baseline. With regards to the mean arterial pressure, both the drugs showed a drop in the blood pressure by about 12 millimeters of mercury at T1. And throughout the study period, it stayed below the baseline. However, in the carbetocin group, there was a further drop in the mean arterial pressure from T5 to T20. With regards to the ETC, that's the ejection time which was compensated in the oxytocin group, there is a drop from T1 till T20. With regards to the other DPA variables, there was comparable between the two groups. Regarding the secondary outcome, there was a statistically significant difference with regards to the use of phenylephrine, which was much more in the carbetocin group. There were 7 patients in the oxytocin and 5 in the carbetocin group, which complained of chest pain, but this did not achieve statistical significance. Also, the need for additional uterotonics was less in the carbetocin group, which was 3 parturins as compared to 7 parturins in the oxytocin group, but this also did not achieve statistical significance. 5 patients in the carbetocin group had a blood loss more than 1,000 ml, out of which 4 patients had surgical complications. The total blood loss was similar between both the groups. So if we try to discuss this case out, there was global vasodilatation of the large and the small arteries in both the groups, which was quite comparable. As regards to the heart rate, in the present study, there was a negative chronotropic effect in both the groups, which was much more in the oxytocin. But the other studies, like with the Motted et al., have shown that there is significant increase in the heart rate within 30 to 40 seconds of administration of oxytocin as well as carbetocin. And this also depends whether the drug is being given statin, whether it's being given IV over a period of 1 minute, or it's given as an infusion over 5 minutes. With regards to the need of additional uterotonics, the present study denoted that there was a decreased use of uterotonic with carbetocin although it did not achieve statistical significance. But the same results have also been published in the meta-analysis by Onmuk et al. In the publication of 2019, as well as that of 2020. There has been a difference in the vascular activity of both the drugs, which could be accounted because of the way the two drugs act on the different receptors. Pasani et al. Have shown that although oxytocin activates both the G protein coupled oxytocin receptors, the GQ, GI, as well as GO, along with the vasopressin receptors, the V1A and the V1B. But carbetocin only has a selective action on GQ oxytocin receptor, and it is rather an antagonist on a vasopressin receptors. The strength of the study was that it was a double-blind randomized design, so it avoided the operator and the selection bias. But however, there are certain limitations because the authors did not capture the transient hemodynamic changes which occurred over the first 2 minutes, because 1 minute it took for the drug to finish, and then another 1 minute before they started the capturing the data. Also, the dropouts constrained the T20 and T60 measurements, which reduced the power of the study. And lastly, they also excluded the cardiac compromised patients, which according to me, it would have been the most pertinent thing to use carbetocin in this group of patients. So to conclude, there have been minor differences in the cardiac performance and the vascular activity, which can be attributed to the differences in the receptor signaling pathways. The heat stable nature of carbetocin, it may prove beneficial, especially in low resource centers with low and middle income countries where transport and storage of oxytocin is quite challenging. Also, the single dose administration of carbetocin would be helpful as it averts the need of dose calculation, and it would be helpful in our setups where we have already very compromised healthcare systems. We are already stretched with the number of people we have to administer these drugs in rural centers. The future holds using these drugs in cardiac compromised parturients so that we have specific guidelines whether they can be used in such patients where it would be most promising. And this is the need of the hour. Thank you.
Thank you, Anjeleena. And now we go on to the last article, and I invite Shilpa to talk about the third article, the third important study we have looked out for. You're sharing your screen. The gastric emptying.
Hello, everyone. Can you hear me?
Yes.
And can you see my screen?
Yes.
Okay. First of all, I would like to congratulate the entire team of Indian College of Anesthesiologists for commendable job and academic contribution. I think they have reached a level of excellence and brilliance in this. This is the 167th webinar. This is amazing. And I would like to give a big round of applause to them to keep the academic interest going. Okay, so coming to my topic, there has always been a perpetual dilemma regarding oral feeds during labor. Now, this particular article, Pregnancy and Labor Epidural Effects on Gastric Emptying, a prospective comparative study, which was published in Anaesthesiology last year, will clarify our approach to a great extent. Now, what we already know about this topic is that gastric emptying is delayed in parturients, and peripartum aspiration has always been a matter of great concern. However, there is a lack of reliable data on gastric emptying of solid food during labor, and that is why there are discrepancies between current guidelines regarding fasting of solid food among parturients. There are different guidelines in different countries. The USA and the SOAP guidelines they allow only clear fluids during labor, whereas the European guidelines allow clear fluids, but also allow low residue food during labor. In India, the practice is random, not standardized, different in different nursing homes, hospitals, but institutions probably follow their institutional protocol. For example, in my institution, we allow only clear fluids during labor, which will include like a clear vegetable soup, coconut water, clear apple juice. So this particular study, coming back to it, we know that labor pain and opioids both delay gastric emptying, and the gastric volume was larger within first hour after delivery in those who had solid food during labor compared to those who fasted for solids. There is no study till date which has assessed the gastric emptying of light meal during labor. Thus, the authors came up with this prospective comparative study aiming to determine and compare gastric emptying after intake of a standardized light meal in laboring women with epidural, without epidural, pregnant women not in labor, and also a controlled non-pregnant women using a reliable non-invasive ultrasound tool. Now, they hypothesized that the gastric emptying fraction of a light meal measured during 15 minutes to 1.5 hours period would be reduced by at least 30% in parturients with labor epidural compared with the non-pregnant control group and the pregnant control group. So they started this study on volunteers and parturients who were 40 or less than 40 years of age with no medical disease, that is ASA grade 1 patients, fasted 6 hours for solids, 1 hour for clear liquids, and were on empty stomach on the first ultrasound. The non-pregnant control group was confirmed with negative urinary pregnancy test. The pregnant control group were more than 32 weeks of gestation, not in labor. The pregnant study group, which received epidural, and those who did not receive epidural were both more than 38 weeks of gestation and in labor. The study ensured that they included patients who were very comfortable with the epidural. That means it was an effective epidural with VAS pain score less than 3 in all the patients. Those who had higher VAS scores were excluded from the study. Also, patients who refused to participate, multiple pregnancies, risk of preterm labor, any pathological pregnancies, or if baseline ultrasound showed filled up stomach were excluded from this study. Now, coming to the ultrasound examination of the gastric interim, this was performed in all the 4 groups. Lack of appearance of any content in the flat interim was considered as empty interim. Hypoechoic content in dilated interim corresponded to the fluid content in the stomach, and more echoic content in the distended atrium corresponded to solid content in the stomach. Going further, the ultrasound examination of the gastric interim, they also did maximum diameters both in the longitudinal dimension as well as the anterior-posterior dimension, and they were labeled as D1 and D2, which was measured from serosa to serosa between antral contractions. The mean value of 3 consecutive measurements of D1 and D2 were used to calculate the interim cross-sectional area, which was used using the following formula that you can see on the screen. Now, a combination of qualitative and quantitative assessment is highly accurate in determining the status of gastric contents in adults. So 10 subjects were enrolled and tested in each group. Non-pregnant women was the first group. The second group was the term pregnant women which are not in labor. The third group was parturients in labor with absolutely no labor analgesia. And the fourth group was parturients in labor with epidural labor analgesia. So initial ultrasound was done to ensure that the stomach is empty and having an antral cross-section area of less than 500 millimeters square in pregnant women and less than 340 in non-pregnant women. Now, after this, what is light meal? Each subject was given 125 grams of yogurt, which was equivalent to 120 kilocalories within 5 minutes of finishing the ultrasound. And in the epidural group, they were given this light meal within 1 hour of initiation of the labor epidural analgesia. The ultrasound of antral area was performed at 15 minutes, 1 hour, 1.5 hours, and 2 hours after the test meal. Also, the fraction of gastric emptying at 90 minutes was calculated and the half time to gastric emptying was determined. The statistical analysis was done using the following tests that you can see on the screen. Coming to the results, there was no statistically significant difference in the demographic data such as age, weight, BMI, gestational weight gain, fasting time, parity, gestational age, cervical dilatation, VAS score, etc. All of them were calculated and were comparable in all the groups. However, there was some statistically significant and very interesting findings which were seen in this particular study. Obviously, the VAS pain score in the epidural group was significantly low as compared to the non-epidural group. Now, in the parturients in labor who took an epidural, so in the epidural group, there was increase in the size of the antral area at 15 minutes, 60 minutes, 1.5 hours as compared to the baseline values. And there was no difference at 2 hours and the baseline values. So this probably means that the stomach was empty by the end of 2 hours in the epidural group. Now coming to the non-epidural group, there was increase in the atrial area from 15 minutes to 2 hours as compared to the baseline. And the antral area at 90 minutes and 120 minutes was significantly higher than the pregnant control group. And at 2 hours, it was higher than the epidural group. So what does this actually mean? This will be easily understood by this particular graph. Now, as you can see here, the blue and the blue line is the non-pregnant set of patients. Okay, so the x-axis here shows the baseline, the time, and the y-axis shows the antral area in millimeters square. So the non-pregnant patients, the antral area was much less at the end of 2 hours, as you can see here. It was around 150 to 200 millimeters square. Now the pregnant patients who were not in labor, as seen in the orange line, their antral area was more than the non-pregnant. That means the gastric emptying is slowing down in pregnant patients. Then coming to the top two lines, which is red and green lines, these are the laboring patients. Now the green line shows the patients who have taken epidural. So it is clearly seen in this graph that the antral area of the parturients who took an epidural was significantly less as compared to the non-epidural group of patients at the end of 2 hours that you can see here. So what does this mean? Okay, now also percentage of stomach contents which were emptied at 90 minutes was 52% in non-pregnant women, 45% in pregnant women, and 31% of stomach contents were emptied at the end of 90 minutes in the patients who took epidural, while only 7% of the stomach contents were emptied in the patients who did not take an epidural, which was statistically significant. So coming to the discussion, the gastric emptying depends on the meal composition and the gastric content. The gastric emptying of light meal is 1.5 to 4 times slower in laboring women who received epidural than in non-pregnant and the pregnant women. Epidural analgesia affects the gastric emptying in two opposite ways. One is it minimizes the acute pain related to gastroparesis via epidural pain relief. And secondly, it reduces the gastric motility and delays the gastric emptying due to epidural opioids. Now, epidural labor analgesia improves gastric motility and emptying compared to that seen in those without any epidural analgesia. Coming to the literature review, the gastric emptying of solids differs from that of fluids as seen in multiple studies. Also, it was seen that the solid food remained in the stomach for many hours after onset of labor in 2/3 of laboring women who received epidural analgesia. Gastric volume is higher in immediate postpartum period in women who were allowed solid food during labor compared with those who fasted. And more recent studies suggest that some gastric motility and emptying persist in laboring women who have received epidural analgesia as compared to those who have not received any form of labor analgesia. So coming to the conclusion of this particular study, gastric emptying in parturients after a light meal was delayed. Labor epidural analgesia seems not to worsen, but it facilitates the gastric emptying, unlike what we usually thought. And we should allow women in labor to consume a light meal, but caution should be taken about permitting solid food during labor, especially when no epidural analgesia or any other form of analgesia is used. Also, gastric ultrasound could be useful for monitoring gastric contents for guiding the decision to whether fast or feed during labor. This particular study had certain limitations. Investigators could not be blinded to the study group. Accurate assessment of the gastric emptying of the light meal required that only parturients with empty stomach were included. It can therefore be assumed that we included parturients in whom some gastric motility persisted, and that results cannot be really generalized to all parturients. In this particular study, only non-obese women were included. So impact of obesity on gastric emptying of a light meal in parturients remains uncertain and should be assessed further as the prevalence of obesity is exceeding and increasing worldwide. So coming to the final recommendation of this study, solid light meal could be allowed in uncomplicated laboring women and those at low risk of operative delivery within at least the next 2 hours. Solid light meal could probably be allowed in women without epidural labor analgesia who are at low estimated risk of receiving general anesthesia within at least 4 hours. And gastric ultrasound could be a useful aid for monitoring gastric content in parturients, and it can be a guide to decide whether to fast or feed during labor. Thank you so much.
Thank you, Shilpa. And so now all these articles are open for discussion. And there were 2 questions in the chat box. I think one of them was for Kajal. Kajal, is CRI available in India? And if yes, what is the cost? I think
Ma'am, actually, I discussed that. I didn't find any vendor with this, I did check up Google, and it's not, I didn't find that it is available in India. Even the cost, I could only see the pulse oximeter's cost. The pulse oximeter connecting to a tablet that with the software, I could not find. The cost of that, that pulse oximeter was between 7 to 10 lakhs.
okay. There was another question which comes to, I think, Anjeleena.
Yes.
Can we repeat carbetocin? And what is, if yes, what is the maximum dose that you can give per day? And what is the frequency of repetitions?
Ma'am, presently, we do not have any literature where it says that it can be repeated, because most of the literature says that it works, the single dose is as effective as 16 hours of oxytocin infusion. And in case you find that your patient still needs another dose, then probably it would be worthwhile using some other line of utrotonic, either misoprostol, which works very nicely if you give it buccal misoprostol, 400 to 600 microgram, if the patient's under spinal anesthesia, or you could repeat methylergometrin, which can be given IV, provided you do not have any contraindications for it.
So you have been using carbetocin now for a long
Yes.
time. I think for a year now you have been
Yes,
using.
ma'am. Yes, ma'am.
So do you find any requirement for subsequent utrotonics when you're giving carbetocin?
Most of the times, no, but some of the surgeons still prefer using oxytocin once the patient is shifted to the post-anesthesia care unit, because they are still not very confident, just in case the patient does have a PPH later on.
So you mean to say that you have used carbetocin and then additional doses of oxytocin are being given? So
By
it is
some-
being multiplied.
Yes, but that depends on the obstetrician. I think they also have to get familiar with the new drug and have the confidence level in that.
But then would you be worried about multiplication of the cardiovascular effects of two uterotonics there?
Most of the studies have not shown any much difference between carbetocin and oxytocin
No,
with
it's
regards
not
to
between, because you are giving it in addition. The carbetocin effect is still there and we are adding oxytocin.
not really, ma'am. No.
Yeah, you do not find any. Mhm. And as you said that at present, we should not be using carbetocin in hypertensive and preeclampsia patients.
There
Yes.
have been
Yes.
few studies where there was this study where they had compared syntrophin with carbetocin, and they found that it can be used in hypertensive patient as well. And there's another study done by Amin Sharif, where they had used it in cardiac patients with high Cardiac score 2, between 4 to 8. And they also found that it can be safely used in these set of patients. But I think still we need to do more studies have to come up before we start using them in our guidelines.
Kajal, apart from the use of CRI in forewarning us about obstetric hemorrhage that is happening, and it does not correlate with the MAP also. So do you think we could find out the status in those patients where we have anesthetic sympathetic paralysis because of the anesthetic agents? Do you think in future this could be used there, or has it been used in trauma? Situation?
Ma'am, it has been, it is to be tried. Even the authors felt that since this is showing like a good response, like the predictability is good. So this should be tested in patients who are undergoing different types of anesthesia, because with general anesthesia, they found that CRIs are, better correlated. Now they want to see it with anesthetic sympathectomies as well. In cases of trauma, actually, most of the time, the trauma patients who are not undergoing anesthesia are more often studied than those who are anesthetized, like trauma on arrival when they are bleeding. So that is the time most of the studies have been conducted. So I think it will be good to study the effect of anesthesia, like regional sympathectomy and CRI.
And
So the audience sitting, ma'am, the students who are sitting, maybe they can, if the equipment is available to us in the near future.
yeah. And in the 4 patients of preeclampsia that were studied in this article, so do you think there would be any difference in normal patients and preeclampsia patients in their baseline CRI values?
They have shown a higher CRI values because of the altered vascular tone. And since there were very few patients, this also needs to be studied further.
Because there has to be this thing that in preeclamptic patients, you'll always find a higher CRI maybe.
Higher CRI.
And Shilpa, what is your you talked about your practice, how you give fluids, only fluids in labor, right? But remember in olden times, the mothers and mother-in-laws used to feed wheat halwa with jaggery and hot tea or hot milk to all the laboring parturents. Yes, that practice still persists in rural India, and it is always given on the sly without the healthcare workers knowing about it. So what is your practice in Gangaram Hospital, Anjeleena?
Ma'am, we allow only liquids, clear liquids to them once they are in labor.
And okay, Kajal has disappeared.
Yeah.
So when you give these clear liquids, Shilpa, do you think it should be supplemented with your antacid prophylaxis? You give them antacid prophylaxis or you do not give them?
We normally give antacid prophylaxis to all our patients. And I said our antacid prophylaxis is normally, if they are in labor, it is tablet pan 40 milligrams and MSET tablet 4 milligrams. If they are scheduled for section or they are of high risk for, predictability for cesarean delivery, then we also give them injectable form if we don't have even 2 hours or 3 hours to give them antacids. So this is a practice that we follow. I don't know about, I would
Can
like to know what.
Ask, what is the rationale of giving MSET?
It's just anti-emetic. That's it.
Right.
We are not increasing the gastric motility.
Yeah,
No.
it does make a difference. That's what.
Very true.
So maybe just giving Pantacid might work, because we are not expecting these women to have as such.
So
vomiting.
actually, labor itself causes nausea in 40% of women. That is a normal, that's what the studies show. And that is why our institutional protocol is to give antiemetic to all the patients so that they don't have nausea, retching, and eventually, vomiting. So their comfort zone and their satisfaction is much higher if they get MSET.
Right.
I don't know who all practice metoclopramide. Is anybody practicing that?
We are still using it, but mostly for when they're coming for emergency cesarean sections.
Okay.
But still in the districts, a lot of obstetricians still rely on metoclopramide.
Okay. Tablet form or injectable form?
Tablet form. During labor, they do not give injections, and then it's always the tablet form.
So we had few patients who had extrapyramidal reaction, and it is really not good to have, a full-term parturient nearing delivery to have extrapyramidal reaction. So that is why we stopped giving it, though we always have Finargan handy, and we also practice the same that Anjeleena just said. If they are not fasting adequately and they are coming for an emergency cesarean delivery, then we do consider giving them injectable metoclopramide.
Any other questions from the audience? And Jayashree ma'am? And not so much of a question, but a remark. Thanks, Sunanda. All the presentations were, of course, very good. Shilpa, what I'd like to ask you, it's very interesting, of course, the study that you have quoted is very, very interesting. And my only thing is that possibly the people, because as Sunanda said, various hospitals, some of them are just keeping them fasting and some have this nariyal pani, etc. So what is your practice? After all these studies, have you changed your practice or is it the same one as you're following? So what do you do after an epidural? Do you allow a light meal or no?
So after an epidural, so first of all patients in our hospital take epidural. Okay, so if there are they are actually very high profile patients who have zero pain tolerance and zero tolerance for even hunger. So generally when the patients are in established labor, when they're about 5, 6, nearing 7 centimeters dilatation, primies, I'm talking about primies, then we always give them clear liquids. That I said, clear liquids can be anything. It can be clear apple juice, coconut water, or a clear veg soup if they don't want something sweet. Okay, but when they are very early in labor, like primary is very early in labor, and we know we have, 6-8 hours with adequate pelvic size, we do consider giving them something like, I mean, there are patients very early in labor who have taken a sandwich, who have taken ice cream, and who have had yogurt or custard. So something which will just, satiety levels rather than anything else.
Any of these, Shilpa, have you had an emergency anytime? Of course, this protocol is correct in your hospital, but such patients, have you had any emergency cesareans in them?
Yes, we have had emergency cesareans in them because of sudden fetal distress,
Yeah.
generally fetal bradycardia. But fortunately, because all of them have epidural in place, so
Yeah.
we have initiated and activated the epidural and managed to do section only under epidural,
Yeah.
and none of them have really aspirated.
True.
Fortunately.
Thank God. Then Shilpa, true, I know your hospital is a very, very high profile one. Kajal, what about your hospital? The class of people are absolutely different. Of course, I know you get VIPs as well. There's no doubt about it. But aap log kya karte ho? What is your protocol?
For keeping
First of
them,
all, how often are you giving the epidural, Kajal?
ma'am, it's not very often because of the workload. And as such, the patients are allowed to take clear fluids and non-pulpy juices. That's all. And
That's
most of them are
interesting.
on IV drips. So like, because there are induced labors and they're high risk labors. So anyways, like they have higher chance of going for cesarean section. So already they are under a big scanner. There are like very few normal laboring women in PGI.
Right, okay. Thanks, Sunanda. Thank you so much. And you can go ahead with the questions. I'm not asking Anjeleena because, of course, we are in the same hospital, but only to say that, yes, the carbetocin, as Anjeleena said, we are using occasionally. But more important than in this is, as we all are on the same page, is the obstetricians that you have to convince. That's the most important thing, because they are the ones who from the, they'll repeat, nahi, bleeding ho rahi hai, now give oxytocin. So they literally force you, just the way for methogen. So now they've come to know that methogen is, we are supposed to go slow. But I think the same thing, education, and for them convincing them is important. What do you say, Sunanda?
Yes, so very important. Educating the obstetricians is so very important, and they go on with their old methods, which they have been following for ages. Now, there was
I would just like to
question.
make, can I make a comment here?
Yes, sure.
Okay, so we have been regularly using carbetocin in our hospital. And fortunately for us, our obstetrician says, carbetocin diya, carbetocin diya. So they are for carbetocin, all of them. And retrospectively, though we have not conducted a study yet on carbetocin versus oxytocin, but retrospectively, when I give it a thought, we have actually not used a second uterotonic in patients whom we have administered carbetocin. And we have given second and third line also in patients whom we have given oxytocin. Also, the hemodynamics, like we have seen hardly any, not significant tachycardia with carbetocin as compared to oxytocin, which is really significant. More hypotension with oxytocin. So I think carbetocin certainly is here to stay and should be more widely used, because it comes out to be a stronger uterotonic with less hemodynamic instability.
What about nausea vomiting, Shilpa?
Huh?
What about nausea vomiting?
No, we have not seen it.
The incidence less as compared to oxytocin? And
so what we practice in our institution is we strictly maintain the blood pressure of the patient to 100% baseline by giving prophylactic vasopressors.
Also,
so if it is,
you're giving Emicet to all your patients.
What happened?
Emicet is also being given to all your patients.
Yes. Yes. Though even if you give MSA to the patients and you allow hypotension to occur, the patient will still have nausea. So this is what we follow. So maybe that is the reason we don't see nausea. We don't allow hypotension to happen at all.
Even at we do give prophylactic vasopressors are given. So even if the nausea is there, it's very temporarily, and it just settles the moment the hypertension is gone.
And Anjeleena, how convinced are the obstetricians now with carbetocin, or
They
only
have
one or two of them?
No, no. Now most of them are, as Shilpa said, they are asking for it because initially I was giving a lot, then I stopped, but again
Okay.
now they have started asking.
Yeah, that's good.
We are back
That's
on
good.
track now.
Okay.
I was at the ASEAN Congress in Bangkok recently, and one of the delegates there stood up and asked a very interesting question. She said, ma'am, you have a collapsed parturient. She's bleeding. She has got PPH. And you're giving your uterotonics. Are the uterotonics really reaching the uterus? Because most of the blood is being relocated to the vital organs. And so all your uterotonic is going right up to the brain. And whatever blood is there in the uterus is all going out. So does the uterotonic really reach there?
Pretty interesting.
Question.
The answer
Very
is
Good
interesting.
question. Yeah.
but probably there would come the role of other things like Bakri balloon, or you may have to consider that, or even a early cesarean hysterectomy.
So, yeah, that's what she was saying, that all these drugs, whether it's your tranexamic acid, your uterotonics, none of them are going to reach there, you know. So I said, yeah, okay, tranexamic, of course, it has a systemic effect, but uterotonics need to have a localized effect. So she was like, why not go in for more of, intramyometrial agents? So why research has to be done on carbetocin, which cannot be given intramyometrial? Why not invest in more intramyometrial uterotonics?
As of now, only carboplast, though it is still not licensed to be injected intramyometrically, but it's still used and I think it works.
Yeah, prostaglandin we used to give, na? We still give. When there's no other way out, we always give it intramyometry.
You cross your fingers and give everything that you can.
Yeah. But as I said, within 6 to 7 minutes, oh my God, she bleeds profusely and goes into an irreversible shock.
So now even the obstetricians have got a low threshold to do obstetric hysterectomy, even if there is one child, or even if it is a primary. In last 1.5 years, we have had 2 patients after they bled for 2.5 hours, and we knew that our radiologist is not really contactable, though we have a cath lab, but he was not in-house in the hospital. So we took consent and we just went ahead with the obstetric hysterectomy. We could save the patient, and without a patient slipping into DIC and all those complications.
Even in
I
our
think,
institute, we started early only.
Other questions there?
Sunanda Taja Gopalan, I think there's one question.
Is there a question there?
I think Dr. Taja Gopalan has asked.
Anyone using
Sulfide.
But this is a very new molecule. I don't think it has been used. It has been just introduced in the market, similar to levosulfuride and all those. So
What is that? Anyone using?
the medical rep just came about 2 weeks back with this. So it's, I think, very new.
So what is it?
Prokinetic types. No, it's when levosulfuride types.
Lisuride.
No.
We use it. I mean, I don't use it, but some of my other colleagues do use it. It's not new. It's quite old, actually.
I don't know, but we have not used it.
They've not used it either.
So that is an adjunct. If you have given all serotonin, receptor antagonist, you have given, we have granisetron, we have themiset, like which works for one dose works for 3 days.
Pulanositron.
Yeah, pulanositron, right? Then we have granisetron. So they're all serotonin antagonists. So look, then we also give Rantac, Pan, everything if the patient have nausea, vomiting. But this, the other drug
is what works in the end.
Yeah.
A dose of Dexa. Okay, ma'am.
The US guidelines say a lot about using Dexa. but presently I don't think so. In India, we are using Dexa as frequently as
Dexamethasone, you're talking about cortisone?
dexamethasone. Yes,
Dexamethasone.
yes.
Yeah. Mm.
It helps in delayed vomiting. It doesn't have an early onset.
Yes.
For those
Has to be
patients who are
given
at
early.
risk of vomiting after 24 hours, it's a good thing to add. But for
Yes.
immediate vomiting, I don't think it adds.
No, not for
No,
immediate.
not for
vomiting.
immediate.
When you have exhausted all your antiemetics, then as a last resort, that is what we give.
This is going off the topic, but today there is the soft launch of remifentanil in India. In Mumbai, it has come today
Okay.
by Themis. So I am very glad that it has finally come after 17 years. I've been waiting for
What's
it.
the name, Shilpa?
Remifentanil, ma'am,
Okay, Remy.
ultra short acting opioid.
Yeah, yes.
So this can probably be considered if the patients
Yeah.
have some contraindication to epidural. Remifentanil is the second best bet for providing labor analgesia.
Analgesia, yes, that's true.
Yeah. So we don't know how expensive it is. That was the only concern. Let's see. I don't know yet.
We need manpower with it if we are using it.
Is to one
And we
nurse.
need to punish to one nursing.
Very true.
So
There's a-
so the company is providing us with the TCI pumps free of cost, because it has to be put in an infusion pump and has to be used in the form of an infusion. So their target control infusion pumps are specially designed for the use of remifentanil. So the cost will be only of consumables to the patient.
So I think the key recommendations from all three are already clear. So I don't think I should summarize it further.
Thank you so much, Sunanda. Thank you so much. It was a lovely appraisal of journal articles today. Truly enjoyed all of them. And it's all because, of course, the moderation by Dr. Sunanda. Thank you so much. And so well presented by Dr. Kajal, Anjeleena, and Shilpa. Thank you so much for accepting our invitation to participate in the webinar. Of course, many of you are participating all the time, but once again, it's my duty to thank you all very, very much. So thanks once again, and we'll be seeing you very soon. Good night. So we see you next Wednesday. Thank you so much, Sunanda. Bye,
Thank you.
everybody.
Bye. Thank you, ma'am.
Thanks, Ranju.
Thanks to Jyoti
Yes.
and
Yes.
Rupa for that lovely.
Thank you so much, everyone.
Yes, Rupsa, thank you so much.
Thank
Good
you so
night.
much, ma'am.
Thank you. And Ranju and her team, and Sanish, Dr. Kanchi, and the others. Thank you so much. Good night and see you all next Wednesday.
Good night.
Thank you so much, everyone, for extending us the opportunity to host the session. So with all your permission, I'm signing off here, and good night.
Good
Thank
night.
you. Thank you. Thank you, Jyoti. Good night.
Thank you.